In the criminal justice system, neglecting adequate hydration and nutrition are considered especially heinous. In Bloomsburg University, the dedicated specialists that investigate these vicious felonies are members of an elite squad known as the Speech-Language Pathology Unit. Here are their stories.
Case 394, the People versus Holy Saint Crustacean Nursing Facility. All rise for Judge Roma.
Please be seated. Jury, I'd like to thank you for your service. Ms. Baldwin, please report your first witness.
I'd like to call to the stand expert witness Jenna Broski. Your right hand, please. Do you solemnly swear to tell the truth, the whole truth, and nothing but the truth?
I solemnly swear.
Proceed, Ms. Baldwin.
So, Ms. Broski, can you please tell us why you're here today?
Yes, I am here to testify in court regarding a treatment plan that was carried out with a patient at the Holy Saint Crustacean Nursing Facility, a patient who is now deceased.
Correct. You're a witness to the decisions that an SLP has made at Holy Saint Crustacean, which resulted in the death of a patient. Now, for the jury who may not be as familiar with your work, could you please explain to them what the primary responsibilities of your job are, and when it comes to working with a patient with dysphagia, what that really means?
Sure. An SLP's primary responsibility is to ensure that a patient who has dysphagia is receiving adequate hydration and nutrition. An SLP is responsible for conducting a thorough clinical exam or evaluation and performing a video fluoroscopic swallow study when necessary to assess the physiology of the swallow.
So we can assume that this SLP perhaps made a change to the patient's diet to assure adequate nutrition and hydration, like you said?
I would assume that the clinician used her skilled clinical judgment to modify the patient's diet in order for the patient to be able to safely intake food and liquid. So yes.
So the clinician changes this patient's diet to assure her safety, you say. Why would thickening her liquids make her swallowing safer than it was at the time that this decision was made?
On that note, let it be known that much of what SLPs do to help patients with dysphagia has minimal empirical evidence to justify it. And this makes it difficult to determine best practices and to evaluate the effectiveness of changing treatments. But with current evidence-based research in our field, we are able to better make clinical decisions that will benefit our clients. Research regarding thickened liquids is growing in our fields, which is great. So to answer your question, I would like to review the clinician's evaluation report and subsequent recommendations for the patient to be able to evaluate her decision.
I understand that, and with that being said, I'd like to present evidence number C16, the clinician's evaluation report.
Bailiff, can I see the report?
So according to those clinician notes, she reported that she performed a skilled clinical swallowing evaluation and a video fluoroscopic swallow study during the week of August 13th. Please read it aloud for the courtroom.
Yes, it says here that instrumentation illustrated that the patient presents with impaired laryngeal closure. Recommended diet change is honey thick liquids.
Yes. Ms. Broski, can you explain why the clinician made the modifications to this patient's diet based on what you've read in this report?
Using her clinical judgment, she concluded that the patient may benefit from thickening liquids due to the patient's impaired laryngeal closure. Physiologically, this makes sense, as thickened liquids may slow down the bolus flow to compensate for reduced laryngeal closure. Steele et al. 2010 reported that there is some evidence that thickened liquids can lead to reduced risk of aspiration, which is what we do not want. We do not want aspiration in our clients. However, thickening liquids can lead to increased oral and pharyngeal residue, reduced palatability, and increased risks of dehydration.
So you're saying that the SLP made some sort of skilled clinical decision that made sense for you for the most part, but yet the patient is dead. Could you please explain that to the nice people of the court?
Counselor, rephrase.
Scratch that. Let me ask you that again. How does the SLP deduce that thickening liquids is the right move to make for this patient?
Well, each patient presents with different strengths, weaknesses, and characteristics of dysphagia. And this means that clinical decisions must be custom-made to each individual. That's crucial. After a thorough clinical evaluation and VFFS, video fluoroscopic swallow study, the clinician should be able to determine the next steps towards treating the patient. A helpful guide I often keep in mind when determining the protocol for modifying treatments and assigning techniques is adapted from Logman 1993's compensatory strategies ladder. Now, not everyone, follows this, but this is a little something that I like to follow when I'm making clinical decisions. First, one should try postural changes, then try techniques to enhance oral sensation in the mouth, and next, one should attempt swallowing maneuvers. And then lastly, one should assign a diet modification. And with this last step, it is really, really important to include collaborative planning with the patient to ensure that diet changes are formulated with the patient's ideals in mind.
Now, in your opinion, did the clinician implement these first 3 steps prior to assigning the diet change?
From the report that you gave me, it seems that the patient's swallow did not improve with oral sensation enhancement, swallowing maneuvers, or postural techniques. So her decision to modify the diet for the patient seemed to be an appropriate next step, as long as the patient is an active participant in the decision-making process.
Now, you are our expert. I heard you talk about collaboration. Why does the patient have to be an active, collaborative role in this treatment decision-making?
This is perhaps the most important factor, the most crucial factor in all therapy planning for dysphagia treatment. Where the SLP's role is to make a recommendation for a diet consistency, the patient is the person who should ultimately decide his or her own diet consistency. The patient has the right to make her own choices, including what she puts into her body.
You're stressing that this is an immensely important factor in treatment. Did the patient agree to the modification in this case?
To my knowledge, the patient expressed that she did not want her diet modified. On multiple occasions, she said this too. Staff members, nursing staff, and this is really not an unheard of claim in the healthcare system. The patient expressed this to a bunch of people, and it's just not an uncommon thing we hear. So.
But you noted before that the clinician made a skilled clinical decision to recommend the change in diet for this person's safety. Why would the patient deny this?
Again, it's the patient's decision. It's their overall decision to make this life change, as changing a diet can change a life. So she can choose to do something that's unsafe for her, such as ingesting a thinner liquid, which could cause harm. But despite the wide clinical use of thickened liquids, a study by McCurtain et al. Found that patients prescribed thickened liquids generally dislike the taste and texture and the uncertainty of the treatment itself. This often leads to a lack of adherence to the diet. And this crucial point is that the SLP needs to ensure that the risks of her decision are explained to her.
So you're saying that the patient has had a choice to make here that it sounds like she did not get. It sounds like the clinician only gave her one option. Thickened liquids are thickened liquids. Is that correct?
Well, there should never only be one treatment option. There should be many. They're just recommendations, really. And their benefits and risks should be weighed and presented to the patient for her to choose which is right for her. A decision should then be made once the clinician ensures that the patient understands the risks and the benefits of particular treatment choices. It appears that the clinician did not provide the patient with these treatment options.
So if the SLP had given the patient treatment options, do you believe the patient would be alive today?
Speculation, counselor.
Withdrawn. If the patient clearly refused the diet modification, as you said, then what was the next step the SLP should have taken to ensure hydration and nutrition of this patient?
Well, typically a clinician would work with the patient to formulate a new therapy plan that would allow for adequate hydration and nutrition to be taken place without the use of thickening agents in liquid. Shared decision making is crucial. Again, I've stated that many times before, and I can't emphasize it enough. So given the fact that the patient engagement is widely recognized as a critical aspect of quality care, it's vital that she be involved in determining treatment methods. And that goes for anyone in general.
So what did the clinician in this case do?
She did not create a new therapy plan. She continued to give the patient thickened liquids.
Even though the patient refused them.
Yes.
Your Honor, let it be known that the expert witness has professed that the clinician in question continued to modify the patient's diet, although the patient refused. Ms. Broski, I'd like to bring up research material that you mentioned earlier by Steele et al. You noted that thickened liquids can lead to increased oral and pharyngeal residue, reduced palatability, and increased risk of dehydration. I'd like to discuss dehydration. How can it impact a person's health?
Well, dehydration poses a number of potential risks to a patient, including xerostomia, which is dry oral cavity, malnutrition, renal failure, fatigue, poor muscle strength, UTIs, pressure sores, ulcers, and even death.
Did you say death?
Yes.
And what was the condition of the patient at the time of death, Ms. Broski?
She was severely dehydrated and developed complications related to her dehydration.
So this nursing facility has a department policy of thickened liquids, which I understand you're aware of. In your professional opinion, would you support the department policy using empirical research?
Although there is generally accepted clinical intuition and anecdotal evidence that has been widely used to support using thickening liquids, and the effects of the control on the speed, duration, and clearance of the bolus, there is limited evidence to suggest that thickening liquids results in positive health outcomes with regards to improved nutritional status and decreasing the possibility of pneumonia.
So in your professional opinion, should the facility reconsider or perhaps revise this policy?
In my opinion, the patient should ultimately have the final say in any diet consistency changes. The patient and their family should be educated on the potential risks and benefits of any diet consistency changes. I feel a team approach should be considered when making any recommendations regarding thickening liquids. So yes, incorporating a patient-directed decision-making approach would benefit all parties involved, as long as the SLP educates the patient and family members on the risks and benefits. To combat dehydration risks, which are something that we really want to combat, we don't want anyone to be dehydrated in our facilities, I believe that incorporating a water protocol would be another beneficial addition to the facility policy. This may be accomplished by offering more fluid via a free water protocol, i.e. The Fraser water protocol. I'm not sure if you're aware, but that is used in many facilities. So this policy should be contingent on a program that's set in place to assure that patients are receiving proper oral care daily to decrease risks of pneumonia in patients who are at risk for aspirating. Oral care is very important. Together, all of these factors may remedy cracks in the current policy.
Well, I feel the expert has said it all today. Nothing more, Your Honor.
Thank you. The court is now in recess.